Okay, so good morning, everybody. We are back to our fourth webinar by Dr. Abhijeet Wahegaonkar once again, and he's going to talk about ulnar-sided wrist pain and approach to management. Over to you, Abhijeet.
Thank you. And good morning, everyone. And this is, again, a privilege to be here with you. And thank you so much, Hitesh and Bobbitt, again, for the opportunity and making this possible to a live audience. My charge today is to talk about ulnar-sided wrist pain, which is a very common problem that we encounter in clinical practice, and something I feel that every orthopedic surgeon should know about. So this topic is something which is very dear to me, and I love speaking about it. I would like to share my thoughts about a very simplified approach to ulnar-sided wrist pain, which is a common problem that you will encounter in clinical practice. No conflict regarding this particular presentation. So what do we know about ulnar-sided wrist pain? It is a very common problem. It is pretty disabling to the patient because of the pain, because of loss of movement at times. It is difficult to understand because there are so many structures in such a small space, and any or many of these structures could result in ulnar-sided wrist pain. It is difficult to treat. It has a myriad of etiology, a litany of pathologies, and so it poses a clinical challenge to all people. And it is often referred to as the black box of the wrist joint, or is also called the low backache of the wrist joint because of its common nature and multiple etiologies. It is very nice, or it is appropriate to think of the DRUJ as a continuum rather than a single entity. And you should take into consideration the distal radioulnar joint, the interosseous membrane, and the proximal radioulnar joint as a continuum. So if you were to kind of think of this as a bicondylar joint, pretty much axis is extremely important in maintaining stability and function of the upper limb. So the painful disorders of the ulnar wrist could result from soft tissue injury. And when we talk about soft tissue injury, we are referring to the TFCC, we are referring to the radioulnar ligaments, the dorsal and the volar radioulnar ligaments, the ulnocarpal ligaments, the capsule of the distal radioulnar joint, as well as the extrinsic tendons and mechanisms. So any of these could result in pain and dysfunction of the DRUJ. And so this is the subset of soft tissue injury. It could result from articular surface injury, such as that of the ulnar head cartilage, injury to the sigmoid notch, triquetrum or the lunate, or the PC-form. So you may have PC triquetral arthritis for that matter. So a patient presents to you who is an elderly patient, no history of previous trauma, pain and tenderness and swelling along the volar aspect of the a useful guide to classify ulnar-sided wrist pain. However, as you can see from the previous slide, they're pretty complex and are often very difficult to remember. So in my clinical practice, I like to think of ulnar-sided wrist pain in a very simplistic manner, which would also help me with deciding the treatment or as to how I should deal with problems when patients present to me. So I like to look at wrist, the DRUJ problems as presenting only with pain or pain with instability or pain with arthrosis. And we'll see in a little bit how this simplistic classification is useful and is kind of a good guideline in dealing with fracture and problems of the DRUJ or ulnar-sided wrist pain. So before we go to the treatment or the investigation part of it, physical examination is of paramount importance. And when you're looking at the DRUJ, again, it is very important and of particular importance that we follow a set sequence of examination. So you could begin from radial to ulnar, dorsal to medial to volar, and then soft tissue and bony examination so that you would not miss any pathology. So again, the styloid process is the most prominent bony landmark that would give you an idea as to where you would be palpating and examining. Besides inspection and palpation, there are certain maneuvers and patients may present with clicks like you see in this particular video. You could do the DRUJ allotment test. You could do the lift-off test. You could look for the carpal sag sign. You could look for caput ulnae syndrome or the Vaughan-Jackson syndrome where the ulna is subluxed, as you would see in inflammatory arthropathy such as rheumatoid arthritis. So this is a classical DRUJ allotment test where you can see the ulna being extremely unstable as compared to the radiocarpal axis. When you look at this particular video, I always think whether we should call the DRUJ as the DRUJ radio-ulnar or the ulno-radial joint. The ulna perhaps is more important and it forms the primary stabilizing force against the gravity as well as stabilizes the radius to provide strength and is able to carry out function. You also look for something called as a fovea sign, which was described by Richard Berger from Mayo Clinic. And with the forearm in supination, the ulnar styloid process lies more volar. Then you look for the pisiform, and that would give you an idea where the FCU would be. And from this particular picture, the finger is now between the ulnar styloid process and the flexor carpial laris, and deep palpation around there would give you the fovea sign. And if this is positive, or if there is tenderness when you do this particular test, it indicates a tear of the ulnocarpal ligaments, such as the ulnotriquetral or the ulnolunate ligaments, or a foveal dissociation or a foveal disinsertion of the TFCC. And this particular test, very interestingly, is almost 95% sensitive and specific, and is a very good test. However, it has a low differential specificity in differentiating between an ulnocarpal or a TFCC tear. However, if this test is positive, it is always advisable to scope the wrist joint in order to find out whether it's an ulnocarpal or a foveal insertion of the TFCC. You may have, like I said, a subluxation on imaging. After you completed your clinical examination, you would order a test, a radiological investigation. So we usually diagnosis, and when you have a patient who presents with pain alone, this could either be because of a central TFCC tear. It could be because of a split tear of the ulnolunate or the ulnotriquetral ligaments, a capsular stretch, or a tear of the lunotriquetral ligament, or from synovitis. So these are kind of the most common differential diagnosis for a patient who presents with pain alone. Again, I repeat, there is pain alone and no instability or arthrosis of the DRUJ, and then the most common differential diagnosis would be as is listed in this particular slide. When you have a patient presenting with pain and instability of the DRUJ, this is usually because of a tear of the radioulnar ligaments or a transverse tear of the ulnocarpal ligaments, a tear of the joint capsule, a tear of the ECU subsheath, or TFCC avulsion. Now, LT dislocation resulting from a tear of the LT ligament is again something that you should keep in mind when you are considering instability. The third scenario is pain with arthrosis. This could be from an ulnar impaction syndrome, and you usually do an ulnar head resection, as we had spoken about in the wrist arthroscopy talk. So you remove the head of the ulna that is proud arthroscopically, and that would resolve the conflict. And you can see from this particular slide, the ulnocarpal abutment here has been resolved by resection of the distal ulna. So keep that in mind also. And again, I repeat that we need neutral X-rays to put into evidence this the change in the variance. The second scenario where you have pain with arthrosis is a pisotriquetral joint arthritis. It could be from the DRUJ joint proper, which may be because of a malunion of a distal radius fracture that is resulting in DRUJ arthritis. So coming back again to where we started from, when you're looking at DRUJ, ulnar-sided wrist pain, a simplistic classification where you're looking at patients with pain or pain with instability and pain with arthrosis, it becomes a lot easy to determine the line of treatment for these patients. So the usual recommendation for people who come with pain alone, we begin with non-operative conservative treatment that may involve splinting, that may involve NSAIDs, local steroid injection, physiotherapy, modification of activities, and a reasonable time frame where people can perhaps recover. Now, patients who fail to, to respond to non-operative treatment would undergo or would merit some kind of a surgical intervention. And I'm sorry, and arthroscopy is the gold standard for dealing with such pathologies. And when you put in your scope, you would find either a peripheral tear, a central perforation of the TFCC synovitis, and just a simple debridement. If it is a peripheral tear, you would repair it, and that would give you a good outcome, or the patient would be relieved of his symptoms. Now, patients presenting with instability, it is debatable whether there is any role for non-operative treatment, but you might want to offer that treatment. And if a patient demands treatment or relief of pain, or if non-operative treatment has failed, you would go in for operative treatment, wherein, for example, if there is a TFCC tear, you would repair the tear. If there is a foveal avulsion, you would do arthroscopy-assisted foveal reinsertion of the TFCC. Now, coming back, for example, to the patient where I showed you the instability in the previous video, this is an arthroscopic assisted reinsertion of the TFCC, immediate intraoperative, postoperative video, and you can see non-operative line of treatment with splints, therapy, a steroid injection at times, modification of activities, and then people who fail to respond to non-operative treatment, you would embark on surgical treatment. And that would involve salvage procedures such as a Darras procedure, stabilized Darras procedure, where you would stabilize the proximal stump of the ulna with a tenodesis using either the FCU or the ECU tendon, hemiarthroplasty of the DRUJ, or total arthroplasty of the DRUJ. This particular prosthesis is called as a Shecker prosthesis, which is perhaps one of the best options that is available for very chronic and very difficult DRUJ problems. So to recapitulate, you have patients presenting with pain, but a stable distal radial joint with a normal imaging. You would first begin with non-operative treatment, and if they do not respond, you would either do a debridement surgery or maybe a synovectomy perhaps, or a repair of the peripheral tear of the TFCC. You have patients presenting with instability. The joint is grossly unstable in all rotations or in one direction. You have abnormal provocative imaging. You would embark on stabilization surgery. If it is an acute or a subacute presentation, you would attempt an arthroscopic repair. If it is a chronic presentation without arthritic changes, then you would embark upon a tenodesis procedure such as the Adamberger procedure. The third scenario, where patients are presenting with arthrosis, there is pain with loading or with strenuous activity, and there are abnormal plain films such as, what I mean by abnormal is the X-rays demonstrate arthritic changes, or the CT scans are also showing arthritic changes, and conservative treatment fails, then you would suggest a surgery to your patients, which would be salvage procedures, where arthroplasty not available, or if you're not trained in arthroplasty surgery, even resection surgery, such as the Deras procedure or the Sovic-Aponji procedure, work very well for such patients. So with that, I thank you for your attention. I hope this talk has covered in a comprehensive manner how to deal with patients who present to you with ulnar side wrist pain. And if you have any questions, I'll be happy to take questions. Thank you.
Thank you, Abhi, for the live webinar. And I think there are no more questions, and there are some people who are online, but they don't have any questions. So that means they've understood everything.
No problem. Thank you.
Okay, so thank you once again for joining us. We'll do yet another meeting very soon.
Sure. I appreciate
Thank
it.
you.
Thank you so much.
Thank you, Abhi. Thank you once again.
Bye. Bye.
Bye.